Welcome to this explainer, where we're going to act as medical detectives. Interpreting plain abdominal radiographs can feel, well, a bit daunting, right? It's like looking at a chaotic mess of shadows. But it really doesn't have to be. While CT scans are obviously the gold standard these days, plain films remain an incredibly rapid, first-line tool for evaluating things like bowel obstructions, toxic megacolon, and suspected viscous perforations. So today, we are going to master the BBC framework, also known as the Abdo X system. We're going to use this systematic framework to sweep the crime scene of an abdominal X-ray, uncover life-saving clues, and ensure you never miss subtle or life-threatening pathology again.
Here is our roadmap for the investigation. We'll cover 1. Technical adequacy, 2. Bowel gas pattern, 3. Bones and soft tissues, 4. Calcifications in organs, and finally, 5. Spotting radiological emergencies.
Okay, let's start with step 1. X-ray technical adequacy, preparing the crime scene.
Before we even think about analyzing any anatomy, we absolutely must systematically verify that the image in front of us is clinically adequate for our investigation. You've got to check the patient details, identify the projection, and ensure the film extends all the way from the diaphragmatic domes down to the inferior pubic rami. Verify the name, the date of birth, the medical record number, and the exact timestamp. Then, make sure the lateral flank soft tissues on both sides are actually included, because let's face it, if you don't have the whole picture, you literally can't solve the case.
Now, depending on gravity, different projections tell us entirely different things. An AP supine film is your standard initial view. It's fantastic for checking bowel distribution, loop diameter, and organomegaly, but actually, it's highly insensitive to small volumes of free peritoneal air. So if you suspect a perforation, guidelines recommend an erect chest X-ray, because that horizontal beam perfectly captures the upper diaphragmatic domes. But wait, what if your patient is simply too unstable to stand? Well, then we use the left lateral decubitus, or LLD view. The patient lies on their left side for about 10 to 15 minutes, which allows any free air to rise and pool between the right liver border and the abdominal wall. And why the left side down? It's a neat trick. It prevents free air from being confused with the normal stomach gas bubble.
Moving right along to step 2, the Boyle gas pattern, which represents the first B in our BBC framework.
To identify abnormal bowel dilation, seasoned clinicians rely on a really fundamental, completely unforgettable clinical reflex. When you are looking at the bowel gas pattern, you are primarily assessing caliber, and for that, we use a very specific rule of thumb. The 3-6-9 rule. Lock these limits into your mind right now. 3 centimeters maximum for the small bowel, 6 centimeters for the large bowel, and 9 centimeters for the cecum. If the small bowel is greater than 3 centimeters, or the colon is greater than 6, you are looking at abnormal dilation. And pay special attention to the cecum. Any diameter exceeding 9 to 12 centimeters carries an incredibly high risk of dilatic perforation. But here's the catch. To apply the 369 rule, you first have to know exactly which part of the bowel you're interrogating. So how do we tell them apart? Look closely at whether the mucosal lines cross the entire width or just partially, and check if the location is central or peripheral. The small bowel is central and features valvae canientes. These are mucosal folds that form complete, thin lines extending all the way across the bowel width. The large bowel, on the other hand, sits peripherally in a frame-like distribution. It features haustra, which are sacculations with lines that only extend partially across the lumen. Plus, the large bowel often contains solid fecal material, which gives it this characteristic mottled appearance.
Let's shift gears to step 3. Bones and soft tissues, the second B.
Now we're shifting our detective lens entirely away from the bowel to investigate the solid structures. We must trace the solid organs, check the skeletal structures for fractures or metastases, and ensure the psoas margins aren't blurred. Start by inspecting the silhouettes of the liver and spleen for organomegaly. Next, trace those renal contours. A loss or blurring of the bilateral psoas lines is actually a massive clue. It can point straight to a retroperitoneal hematoma or an abscess from something like acute pancreatitis. Finally, run your eyes over the lumbar spine and pelvis, checking for lytic or sclerotic lesions or even signs of ankylosing spondylitis.
That brings us to step 4, calcifications in organs, the letter C in our framework.
This step requires us to carefully scan the abdomen for abnormal radio-opaque calcifications. But just think about this massive disparity for a second. You will easily spot 80 to 90% of renal calculi, but only 10 to 15% of gallstones are actually visible on a plain film. It's a classic pitfall. Just because you don't see a gallstone on an X-ray doesn't mean it isn't there. Their radio opacity is just remarkably low. While you're scanning, also keep an eye out for pancreatic calcifications, which strongly suggest chronic pancreatitis, and look for calcified abdominal aortic aneurysms or those completely harmless pelvic phlebolyths.
And finally, step 5, spotting radiological emergencies, life or death clues. So this is where applying everything we've just organized truly saves lives. We're looking to catch high-stakes surgical emergencies. When you spot a dark patch of gas on a film, you have to ask yourself this critical question to determine if a patient needs an emergency laparotomy. Distinguishing normal gas from free extraluminal gas relies entirely on understanding how gas behaves under gravity and how it interfaces with abdominal structures.
It works like this. Normal intraluminal gas only outlines the inner mucosa of the bowel. But extraluminal gas from a perforation creates an entirely new interface that renders normally invisible ligaments sharply visible. Think about the physics here. The outer surface of the bowel normally rests against soft tissues of identical radiodensity, so it's completely invisible to us. But when a hollow organ perforates, free air escapes. This dark radiolucent gas creates a stark new border against the bright radioopaque soft tissues, suddenly highlighting the outside of structures.
A properly performed erect chest X-ray is astonishingly sensitive for this. We are talking about catching as little as 1 to 2 milliliters of free subdiaphragmatic air forming a crescent sign. If the patient sits upright for 10 to 20 minutes prior to the exposure, that tiny volume of free air naturally rises to the highest anatomical point. On the right side, the dense liver provides this sharp, beautiful contrast, making that dark crescent easy to spot. Sometimes, the gas even tracks across the midline, beneath the central tendon, allowing you to see the entire diaphragm as one continuous thin white line.
But what if the patient is unstable and has to lie flat? In a supine position, free air collects anteriorly. This gives us the paper-thin wriggler sign, also known as the classic double wall sign or the massive oval football sign. Because gas is now present both inside the bowel lumen and outside in the peritoneal cavity, the bowel wall itself becomes visible as a discrete, paper-thin white line. You might also see gas coating both sides of the vertical falciform ligament in the right upper quadrant, or small, sharp, triangular pockets of dark gas settling between overlapping loops of bowel, which is aptly named the triangle sign.
Moving from perforations to obstructions, when you're hunting for a volvulus, remember this handy geographic rule of thumb. The sigmoid coffee bean points right, while the cecal comma points left. A volvulus is basically a torsion, a twisting of the bowel around its mesentery. Sigmoid volvulus is the most common, often seen in elderly patients, and shows up as a massively dilated, inverted U-shaped loop, the coffee bean, with its apex projecting superiorly and pointing toward the right upper quadrant. A cecal volvulus, on the other hand, often affects younger patients with a hypermobile cecum, and its apex points up toward the left upper quadrant.
Now, a quick warning. Before you rush the patient to the OR for a perforated viscus, you absolutely must rule out a classic imposter, the Chilla-Diddy sign. This false suspect happens when a segment of the colon just slips up between the liver and the right diaphragm. So how do you interrogate the image to tell the difference? A true perforation gas crescent is 100% translucent, smooth, and completely featureless. But if you see thin white lines extending partially across that space, those are haustral folds, which proves the air is safely inside the colon, not floating free in the abdomen. So, the next time you pull up an abdominal radiograph, are you going to just trust your intuition? Or will you use the BBC framework to meticulously interrogate the evidence? By verifying technical adequacy, mastering the 369 rule for bowel caliber, systematically scanning bones and calcifications, and leveraging the physics of gas, you completely transform from a passive observer into a precise medical detective. Thank you for joining me on this explainer. The next time you look at a plain film, will you see a chaotic mess of shadows or a clear, actionable map of clues? Keep your framework structured, keep your eyes sharp, and I'll see you in the next one.